motion to approve the minutes.
So moved. Second.
Any discussion on the minutes? All in favor, say aye.
Aye.
Opposed? The ayes have it. And item 2 on our agenda is a discussion regarding the City of West Allis self-funded health and dental insurance plans, funds and funding levels, plan design, and premium contributions.
Mr. Chair,
Ms. Grill.
Rebecca Grill, City Administrator. I'm joined by Alex, who is with Horton, our benefit consultant, and Peggy Steno, our finance director. After the last couple meetings, we thought it would probably be a good idea to go back and talk about the budget and the budget implications of our health plan and things like that, because I think there's a lot of misunderstanding and misinformation that's being perpetuated by some people. So I just wanted to go through that first. I know most of you are familiar with it already. So as we talk about every year with our budget, we have a number of fiscal constraints. As time goes on, as the city infrastructure gets older, the constraints become even greater. So the biggest impact for the City of West Allis is the expenditure restraint program. I'll get into a little bit more about what that is in the following slide. We also have facility repairs and maintenance that we need to do. We had a facilities audit done, I believe it was in 2017. There's about $60 million worth of repairs and maintenance that needs to be done on our aging buildings. You're also familiar with the streetlight conversion. They've stopped producing our bulbs, and so we have a supply that may last us anywhere between 7 and 13 years, but we need to convert the streetlights. The impact of that on the budget and taxpayers is going to be $40 to $60 million. We also have a number of street and sewer replacements. We're behind on those. Each year, the cost to complete those goes up and up. And then we have also the taxpayer financial limitations. 13% of our residents here are at or below the poverty rate of $25,750. Another fiscal constraint that we're not subject to right now, but we could be at some point, are the levy limits. So going in a little bit about the expenditure restraint program, this is aid provided by the state to municipalities to limit the growth in spending. That means limit the increase of your budget from year to year. It's calculated, it's the last year's payment. The rate of budget growth cannot exceed inflation plus the growth on municipal property values. Our 2020 limit is 1.45 million, and that's about 3% of our annual, less than 3% of our annual budget. So as you're familiar with being on this committee, the revenues that we have must equal the expenditures. We can't spend more than we take in, and then we can't spend more than the expenditure restraint limit to receive the expenditure restraint payment. Going back to the budget, $54 million of our budget is personnel expenses. 16.3 million of that is health insurance. A third of that is for retirees. 86.1% of the general fund budget is salary, wages, and benefits. In our OPEB liability, you're familiar with that, the other post-employment benefits. In 2017, that was $147 million. We made some adjustments to the active plans, and that was reduced to $118.7 million. This affects our bond ratings and our ability to borrow. And I wanted to get into a little bit about what the city's health plan is. The city self-funds its plan, which means we have all the risks of the plan. We don't pay a company to cover the claims and things like that. We cover all of those as they come in. We pay the premium share for the employees, and the employees now share that, but then all the claims that come in, we have to budget for through property tax and through the premium share that people pay. We have a lot of claims, millions of dollars that claims come in. Some people go through some challenging situations in their life, and they might have utilize our insurance plan heavily one year. We do have stop loss insurance to cover those catastrophic claims. It currently kicks in at $175,000. Here's a little bit more about the fully insured versus the self-funded. The fully insured benefit levels are determined by the insurance company. We pay the premiums to the insurance company, and then the premiums are based on your size, population characteristics, and utilization. The claims are paid, like I said before, by the insurance company, and all the risk is assumed by the insurance company. People that go with fully insured plans know each month what they're going to be paying out. The city's plan is not like that. An example of a fully insured plan that the city does have is our Care Plus dental plan. Self-funded plans, the benefit levels are determined by the employer, subject to the budget. Premiums that we pay the city taxpayers as well as employees and retirees, they go to the city health fund, and they're based on actual cost, and they're calculated by actuaries. We look back on the last 12 months experience, and usually that helps calculate what the premiums may need to be for the following years. Claims are paid by the health fund, and then the risk is borne completely by the city and the funding sources, but it's mitigated through the stop loss coverage. The city's health plans and standard dental plans are self-funded plans. Just wanted to go over a little bit of the changes in the budgeting and personnel and the abilities of cities that were given and taken away, and then how the city chose to implement that over the past few years. And as you're familiar with, Act 10 was implemented in 2011. It required employees to contribute 50% of their pension payment. In addition, previous to that, there was no payments by employees. It was just borne by the taxpayers and the city totally. Additionally, health care insurance contributions, employees are supposed to pay at least 12% of the cost of premiums. Collective bargaining for all employees except protective services and transit employees was limited to wages only. The fiscal impacts of the Act 10 also was a reduction of our shared revenue. The expenditure restraint formula changed from a floor of 3% to a floor of 0%. So what that means for us is, I think we've been coming in at like 2.3
this year.
Okay. So seemingly it was much more previously, plus the shared revenue, the $1 million that was taken out of that. In the 2011 to 13 budget, pension and health insurance were prohibited subjects of collective bargaining. They further specified that. And then in 2013, Act 20 impacted the public safety employees, and it says that they may only bargain for the premium contribution. We're prohibited from bargaining about anything else than the premium contribution, design, selection, and the impacts. So that's very notable of the following slide of what the city has done over the past few years. In the last 12 years, I guess, Medicare was eliminated for new hires. In 2008, the years of service to qualify for retiree insurance was changed from 10 years to 15 years. In 2012, retirees who leave the program aren't eligible to come back. That was added for police and fire unions in 2016. The next one, the 2013, Rolling with the Actives began. That was a retirement benefit level adjusting with the actives. That was something that was negotiated with the existing police and fire unions. That I believe is one of the most impactful cost implications for people that have retired after 2013. I believe the agreement to do that was tied with some increases. I read through the packet, but I wasn't present at that. Premium share was also tied to the HRA participation, and then it started with 5 and 10%, 2015, 7.5 and 15. The retiree rate increases mirror the actives through 228.15 in, that should say 3/1/15. In 3/1/15, the weighted premium calculations began as part of the budget process. Prior to me starting here, that was decided that they would do that with, so the actives got 5% increase, the retirees were 11%. If the true cost of the plan were assigned to those groups, the actives would have decreased by approximately 9%, and the retirees would have increased by 20%. In 2016, the premium share went to 10 and 20%. The pre and post 65 retirees were separated because the post 13 retirees roll with the actives. So any plan design changes or anything like that also affect those retirees, whereas the only thing that affects the pre-13 retirees is increases in premiums. So that was the thought process about separating those two. In 2016, we had the network change, 31% reduction in rates during that time. 2017, we didn't change anything with the premium share. The weighted premium was 8.4 for the actives and the pre-13 retirees, and I think that should be post-13 retirees, and then the pre-13 retirees are 9.2. Total benefit package was implemented. Now people have to work here for 20 years to qualify for 10 years of retiree health care. Retiree health care ceases at Medicare eligibility. 2018, we did not change the premium share. The weighted premiums were 5% for the actives, 10% for the retirees. Then in 2019, the premium share, well, that's supposed to be 20. 3/1/20, the police are going to 14%, while the others are remaining at 12 and 20. And then we're recommending the 7% increase for the actives and the 11% for the retirees. So this is just an outline of what's happened over the past few years related to the healthcare and benefits. When we started working with Horton and we had the employee benefit committee, we did survey of our comparables, the cities that we weigh ourselves against, and we looked at the deductibles and the co-insurance level. This is from 2018, so the data's a little bit older. I think, Alex, you're familiar with some of those already going up.
So, for example, the Village of Menominee Falls, when we conducted the survey, they had a deductible under $500. I can tell you that's now up to 2,000, 4,000. Menominee Falls.
Their Medicare people are above that. But
What about the active plan?
I think it's 1,000, 2,000.
1,000, 2,000. So it's since doubled. The city of La Crosse has remained the same. They're at 400, 800. Those are a list of. Oh, and city of Racine, they just went to an HSA plan. So their deductibles are, I believe, 1,500, 3,000 now, and it's everything counts towards the deductible. They don't have any copays. So those are just a few of our clients that are on that list, and they've, besides lacrosse, the other two have changed dramatically since this survey was conducted.
Thanks. Okay. Just to explain about normal retirement age, this is going to make a little more sense when I get into talking about some of the other retiree benefits that our comps have. So general employees, the normal retirement age is 65. Protective service, it's age 53 or 54. And then elected officials will be 62 or 65, depending upon when you started. So sometimes people will take a reduced retirement benefit and retire prior to the normal retirement ages. Some, general employees might leave at age 55, that's the earliest. Police and fire could leave at 50 or so. As we get into the comps, you'll see why this makes a difference. I just wanted to explain what this was. So I just went through the police and fire contracts and highlighted the retiree premium info of the comps. Is it reflecting? So some of them have a different structure for their retirees. You can see Brookfield, they give $500 per month, and then sick leave is included in that. And then there's a biweekly payroll contribution of $115 when you're in active service for your retiree benefit. The Franklin Police and Fire, they both pay, the city pays 75% and the retirees pay 25%. Their premium is frozen at the time when they left. After 2010, any new employees have to have 20 years of continuous service, and they must meet the statutory normal retirement age. So that goes back to the information that I provided on the last slide. With Greenfield, if they retire at the normal retirement, they pay equal but not greater to what they paid as an active until they become Medicare eligible. And then once they're at Medicare eligibility, they are no longer allowed to be on the plan. Menominee Falls, talked a little bit about their benefit plan. They'd work with a trust account and make contributions for those. New Berlin Police and Fire, they have premium payment banks. They can also change their sick leave hours into things, but after 2011, they have 75% of their earnings deposited into a health plan once a year, or actually I think it's quarterly, and then each year it's a 1% more on top of that. New Berlin Police, they have the trust, it's a specific amount, and then it rises by the 1.5%. North Shore Fire, if you're hired after 2009, you would pay 35%, employer pays 65%. I'm not sure, I didn't dig into what it was before 2009. Oak Creek Police, the benefit level modifications, meaning the plan design changes, apply to all retirees. If you were hired after 2015, you don't get any health care. They contribute to a VEBA account, and the information, the amounts are listed up there. South Milwaukee, the retirees have to pay the full premium from age 50 to whatever their normal retirement age, and then the city pays 70% from normal retirement age to 59, and then 95% for 60 to 64 years of age. Same for the police. St. Francis, city pays 80% frozen at the time of retirement. They get coverage for a maximum of 12 years or Medicare eligibility, whichever comes first. TOSA, if you're hired before 1992, the premium doesn't exceed 110% of the preceding premium.
Who's the city's share or the retirement share?
Yeah. I think it's the city share. Yes. And then, yeah, it's more laid out under the police, so then in 2008, people, they have to pay 50% each year, and then the Waukesha city pays 50% of the premium until they become Medicare eligible, and there's no Medicare coverage. I didn't note it in each of these, but the majority of them do not have Medicare coverage, like the city of West Allis has for those people that were hired prior to 2008. I just wanted to go a little bit more over the employee benefit survey that we did with the employees here. We collected information to find out if we do changes in benefits, what's more important to them. And there's a few slides that I included here. This has to do with if your spouse has insurance plan, why do you take the city's instead of that? Mostly it's because the city's plan is better than their spouse's coverage. And then the second would be that's the only option. Their spouse might not have coverage through their employer, or they might not be employed outside the home.
One interesting thing on this slide as we talk about the family savings plan, we don't know what the savings are going to be, but according to this survey, while 40% wouldn't be eligible because they don't have other coverage, that would imply that 60% do have access to our health plan that could benefit from enrolling in the family savings plan. So,
And I believe there were like 300 people that responded to this survey when we conducted it. The employees who reported they were enrolled in their spouse's plan, these are the reasons why they chose that over the city's plan. Mostly, it seems like people didn't understand the question because they were actually using the city's health insurance, but there were a few other actual other responses where people might be enrolled in their parents' plan. The network's more appealing, better coverage, less expensive. I would venture to say that's probably another municipality, but I don't know how many private companies have that, and then, or a retiree plan. This is a little bit smaller, but we're trying to rank the items that were important to employees about the health insurance. The number one thing they wanted to focus on was keeping their health insurance premiums at or at similar levels. The second most important, go from 47% down to 15%. That's maintaining the pre-Medicare retiree coverage. And about 7% were interested in maintaining the post-Medicare retiree coverage. Then we also asked about if they're currently enrolled in the plan, if they would like a broader network, what would they be willing to do? When you put it into dollars and cents, a lot of people then felt that our provider network was adequate. And nearly half of all employees plan to use the city's health insurance upon retirement. So then we talked about rising healthcare costs. What should we look at? Should we do across the board increase or adjust the plan structure? So it's almost a 50-50 split, but 47-53. But this is one of the most important things. The things that are important to the active employees and probably all of people that when they were employed here was the competitive salary and the base pay. That's regardless of their tenure. So I just thought it was important to go through a little of those things. I don't know if anyone has any questions, clarification. Most of you are probably familiar with that.
I will, but I'll wait till we go through these.
Okay. Now Alex is
Alright.
going to talk.
So I too wanted to take a step back and try to explain the situation that's going on, because I don't think I've done a very good job of it over the last 3 meetings. So I want to take a step back and talk about the different benefits that the city offers. So essentially, there's 3 categories of employees and past employees that we're going to be talking about. There are retirees that retired prior to 2013. Over the last several years since they've retired, their plan design has not changed. So they are still under the same health plan when they retired. This generally means they have no deductibles, very few copays, and then very few prescription drug copays. And I'll talk about that in greater detail. The retirees that retired after 2013, they have been rolling with the active plan. So any changes we've made to the active employee plan, they have also been impacted by those changes. And then we have our active employees. Did you want to go through every bullet point, or?
I think the top bullet points are probably the most
important. Yeah, the ones that are bolded. If you want to go to the next slide, this is what I'm talking about. So essentially, we have 2 different health plans. We have pre-2013 retiree health plan, and then the post-2013 retiree and active plan. And then just as a quick reminder, I believe it was July of 2018, we implemented the Humana Medicare Advantage plan. That was a big driver in reducing the city's OPEB liability. And I think that plan, while there was some trepidation to undergo it for the post-65 retirees, I believe that plan has been relatively successful, and we rarely hear any complaints about that plan now. So here is what the plans look like if I retired prior to 2013. I have generally no out-of-pocket costs for in-network services. The closer I retired to 2013, I may have some office visit copays. It's generally $10 or $20, and there may be some emergency room copays. But going all the way back, there is no deductibles, no co-insurance, etc. I either have a $3 or a $5 prescription drug copay, or a $10, $20, $30 drug copay plan. Again, the closer I retired to 2013, I'm much more likely to be on that 10, 20, 30 plan. So I just wanted to lay out a couple of claim examples. The first one is if I'm a member who takes a specialty medication that costs $5,000 per month, my only out-of-pocket for the whole year would be $360. That's if I'm on the $30 drug copay plan. If I'm on the $5, obviously it's $60 per year. So very little out-of-pocket costs. The same example is if I claim example number 2, if I have an extensive inpatient stay for 30 days that costs $200,000, my out-of-pocket is 0. Again, no deductible charges. There are currently 102, although I believe 98 is the new number. So there were a few people that probably moved into the Medicare plan. But when I pulled these numbers, there were 40 singles, 44 employee plus one, and then 14 full families that were enrolled in this plan. This is just a quick outline of the post-2013 retiree inactive plan. There are currently 481 actives and 111 retirees in this plan. It's currently a $100 deductible for single, $300 family. The out-of-pocket maximum is $4,850 or $9,700. Single family, there's 100% co-insurance, so the employee is fully covered after they've met their deductible. There are some co-pays for things like the emergency room, office visits, urgent care, etc., and prescription drugs. Any questions on the current plans before I jump into the options that we have laid out here?
Mr. Chair,
Sure, go ahead.
so comparing to the pre-2013, for those exact same claim examples, what would they be paying?
So if I took a specialty medication,
What would the post-2013
Yep.
pay with these same
yep.
examples?
So I would be paying $100 per month for that prescription drugs, it's 5% up to $100, so I'd be paying $1,200 a year out of pocket. And for the extensive inpatient stay, I'd be paying $100 for my deductible, and then things would be covered at 100% after that. Moving forward, I'd be paying, if we go with the recommendation for the active plan, it'd be $250 plus 10% of the remaining bill up to that $1,000 maximum. So it'd be $1,250 that I'd be paying out of pocket for that same service.
And with the changes we talked about at our last meeting, that affects mostly the pre-2013?
Post 2013 retirees and the actives. So if we go with the original recommendation, the pre-2013 would keep their exact same plan design. They'd just be paying 11%, so they'd still have very little out of pocket for their medical plans.
The 11% bump, would they see the full delta of that?
Depending on where they are in terms of the cap, it could be yes.
Whereas
Yeah.
the post-2013,
They're in the same boat,
Yeah, and they
and they
roll
get
with
the plan
actives.
design changes.
and they roll.
And if they retired in 2016, which was one of our lowest premium years, then they have a larger amount that they're paying for the cap.
Okay, so if we can transition to the big sheet, and for those that are sitting in the audience, there's a pile of these in the back of the room if you'd like to follow along. I think I have about 40 of them printed back there, so. So the original recommendation that we brought forward a few meetings ago now would increase the active premiums by 7% and the retirees premium by 11%. We have all of the same plan design changes that we've been talking about. I do want to point out one addition that we have not spoken about. About halfway down the sheet, it says fourth quarter deductible carryover on the left column, all the way to the left.
It's finished.
It's the thinnest line, yeah.
Oh, yes, right here.
So this came to my attention a few weeks ago that the city still has this built into their plan. This is a very old plan design that a lot of municipalities had. Quite frankly, none of the municipalities I work with still have it. Essentially what it means is if I meet my deductible in the fourth quarter of the plan year, so for our plan that's December, January, and February, if I meet any deductible dollars in that time frame, it would roll over into the following year. So let's say I go for a service in January and I meet the full family deductible of $300. That means for the next plan year, I would have no deductible charges because it rolls over. Yeah, it's an old plan design. I haven't even seen this before, and I've been doing this for 5 years. Right now, it's probably not a huge deal given our deductible levels are so low, but as we look to increase those, that's something I'd like to remove. It's just to get in line with industry standards. So that is a change that was not discussed during the previous 2 meetings that I wanted to point out that we did add. So other than that, the original recommendation stays the same. Is there any questions about that recommendation?
Mr. Chair?
Alderman May.
Again, what's the amount that we need to make up in order to keep the fund going?
So right now our fund balance is about a little over 4 million. We were running the 2019 preliminary numbers today, and it looks like we're going to be at least 600,000 over budget, if not 800,000. And that means higher claims than expected and drug costs than expected, once again, which is seeming to be a trend.
So just for December, it was expected to be 90,000 and it was
That was
120.
a drug, yeah, just for the last half of December, the drugs were $30,000 higher than they ever have been before. So it just keeps on going up.
I guess
So
what
what do we have to make up? It's a tough number. We have to make up a lot. Really, industry standard wise, we need to be between 6.5 and 7 million with our plan size for a fund balance, for run out and things like that.
We're close to 4.
We're close to 4 and we're gonna go
And
down
trending
to
down.
3.5. We're probably at 3.5 already today.
Okay, so the next 3 options that we're going to discuss are an attempt to reduce the premium burden on retirees. So option one would increase the actives for 7%. It would decrease the post-2013 retirees from 11% to 7%. So they would truly roll with the actives. So whatever the actives get in both premium increase and plan design changes, the post-2013 retirees would incur as well. The pre-2013 retirees have a choice. They can keep their current plan design at 11%, or if they would like to reduce their premium burden, they too can roll with the actives. If they choose to roll with the active plan that we're recommending, their premium would not increase for the following plan year. So they change plan designs, their premiums would not increase from this year to next year. They'd have a 0% rate increase. All of the other plan design changes for that new active plan and retiree plan, should they choose it, would be the same as the original recommendation. So all of the same plan design changes, increases to deductible, co-pays, co-insurance, all would be the same.
Mr. Chair,
Alderman May.
why is that in-network deductible amount highlighted?
Probably by accident.
We've had a lot of variations of this as we've been working through it, so
Okay, I
it
just wanna
probably
make
was
sure.
different at one point.
We
And
just
just
tried
never-
to highlight the things that were different, so that should not be highlighted. I think also, I don't know if you're gonna talk about the things on the bottom, those.
If you want to talk about
Sure.
those, I can jump
So
in.
one of the things that we're trying to mitigate and look at the long-term financial health of the city and the cost. So if the committee would go with this, there's some different things that should consider having people perhaps not participate in anymore, but also limit something. So limit the retiree percentage increase to no greater than double than the active increase based on their group cost.
We're talking percentage increases, so the dollar amount was not necessarily.
Correct, percentage increases. Retirees roll with the actives, as Alex mentioned, limiting family coverage to 10 years or age 60.
Can you talk about that 12%?
Okay. The 12% has to do with the premium share percentage. Right now, some people pay 5%, some pay 7.5. Likely, this will go up at some point from 12 to 14 or 15%. They would roll with whatever the actives.
So that 12% is based off of the percentage off the capped amount, not their total cost.
Right.
It wouldn't be 12% of the total premium, it would be 12% of the capped amount, and then any difference they would still be responsible for. I just want to make that clear, because I was confused by it.
Okay, then limiting the family coverage. If someone leaves the plan, they can't come back. Coverage ceasing at age 65 or Medicare eligibility. That's something that would bring us in line with a lot of the other comparables, as I showed you before. But also providing the retirees to the ability to participate in our voluntary benefit plans at their full cost, such as the dental insurance, and vision insurance. We just added the vision last year. Since our health plan only covers the eye exams, this covers, like, I believe per person is $150 worth of
Contacts,
contacts,
glasses.
glasses, yeah, whatever. And then if the city continues to have the Medicare Advantage program, allow the retirees to participate in that at their full cost. I mean, the city's Medicare Advantage program has very rich benefits. So a lot of people that I'm aware of have actually moved off of that, even to save more money per month because of they're paying for the rich benefits. But that's probably dependent upon people's health and their preferences. So those are some things that the committee should definitely consider, trying to balance giving the lower increases with long-term fiscal health of the city.
Basically, those things listed, I'm sorry, Mr. Chair.
No, Alderman May, go ahead.
These things listed at the bottom are those things that bring it with rolling with the actives. Correct?
Some of them,
the
some of it
actives.
just is, conditions of what's going to be offered while they retire.
Got it.
I mean, for most part, if you were hired after 2008 for a general employee, you don't get, you don't have coverage for life. So, you just have it till Medicare eligibility. So, yeah, in that regard, it would be rolling with the actives. The total benefit plan people have it just for 10 years after retirement, so.
Any other questions about option one? Option two then is essentially creating a separate plan for retirees. So the actives would still increase at 7% with all of their plan design changes. Then this plan would allow for all retirees, both pre and post 2013, to have a 0% increase for next year. If they chose that option, their plan design is below. Everything is the same from what we talked about, other than the highlighted change in network deductible. That would increase to $750 single, $2,250 per family. All of the other copay changes and prescription drug changes are the same as what we've proposed with the active plan. So this would allow both sets of retirees to get to a 0% premium contribution. By choosing this plan, if they wanted to keep the plan that they are on today, they could do so at the 11% increase. A lot of the same changes on the bottom are what Rebecca just talked about under option one. Option three is a 7% increase to everyone. If this, obviously for the actives and the post 2013 retirees, they would get the below plan design. Again, everything is the same. The deductible is the only difference. It would be 500 single, 1,000 family. Then everybody in those two classes would get a 7% increase. Then the retirees that retired prior to 2013, they could either take the 7% increase at this plan or an 11% increase at their current plan level. Those are the three alternative options to our recommendation that we've brought forward.
So option three is the one that gives the retirees choices of which one they want to go with. Is that correct?
Well,
Or do they all?
the one that gives all retirees a choice is option two,
Okay,
because they have a choice of staying where they are today or moving to this alternative plan. Really, options one and option three, the only retirees that have a choice are the pre-2013 retirees. The post-2013 retirees are really tied to what the actives do if we don't give them a different choice. Option one and option three for those post-2013 or post-2013 retarees, at least their benefit or their premium share is being reduced from 11 to 7%.
Mr. Chair,
Alderman Vitale.
yeah, I would like to ask you, say an employee that retired prior of 2013, and he choose to opt out from the city insurance, and already is getting, say, if he's 65, and he's collecting Medicare Part A and Part B already. So, when you say that if they go to an insurance HMO, Gold Plus, Humana, or will be a lot cheaper than stay within the city? I'm talking about the 65 and over, once they're on Medicare.
So your Medicare premiums a lot is going to depend on your individual situation. So I can't say whether it would be much cheaper or not. I will say that the Medicare Advantage program that the city offers has shown to be pretty competitive with the marketplace. We have quite a few individuals that elected that plan.
So my question is, what's the monthly premium on that?
The members pay
It's $495.11, and they pay 50%, so
Yeah.
$247.
So I'm talking for myself. So I go with Humana Gold Plus. My monthly payment is 0. So the copay, I mean, even with my prescription drugs, is a lot better than what I had before with the city.
Yeah, and I would encourage all retirees over
You know,
the
so that's why I bring that up, because I think somebody should get educated, spend time on a website and shop around, because there's a lot of good things out there that doesn't cost. So if you go to hospital, you pay the first, say, for 4 days, pay the $300 per day, you know, and, but if you really digest that, I mean, monthly, you don't have no premium, so, and the doctor visit is just as the same, $20 with zero. The one I have, it's zero. To go my family doctor, I paid zero.
Yeah, and I would encourage.
And that's why I brought that up, because I think many people don't realize that they can go out there and shopping, if they're over 65, that's what I'm talking about right now. So, and the fact it is, it's hard to say, but times are changing in the industry of health insurance. So, in private industry, I know people that pay over $300 per month. The coverage is very minimum. You know, they have to pay a lot of co-pays, and that's one of those things that I kind of weigh. You know, I mean, it's sad, you know, to sometimes make changes, but that's part of the life. You know, I learn a lot, so that's why I say that.
Can give you the cost savings.
Yeah, what are the cost
We tried to keep it.
savings in each one of these?
So we tried to make everything cost neutral to the original recommendation, so that the city is not in any worse off spot than what it is today from a financial impact.
So any one of these would accomplish what the original recommendation did as far as.
From a
And ag-
premium standpoint,
And of
yes.
course, you don't have a crystal ball, we don't know how much the market's gonna change in 2
Correct.
years, or.
Or how many people are gonna select what plan and things like that.
Yeah, Mr. Chair, that was gonna be my question next. Now, we've got 4 options sitting on the table. Call this option 0, because it's kind of the baseline. Are you saying the original plus another, or are you saying pick one?
It
of
would,
these?
it would
Say
generally
pick
be
2?
pick one. So our original recommendation stands. They're kind of, at least in my opinion, we've had some discussion about this today. The first 3, the original recommendation, option 1 and option 2, are like 1A, 1B, 1C, in my opinion. So any of those first 3, I think, are the most plausible. Option 3, while it's viable from a financial standpoint, my goal is really to keep the benefits as the benefit level, so when I'm talking deductibles, et cetera, as low as possible for the actives and the people that roll with that plan. Once we get up to 500, 1,000, you know, if we need to make additional changes next year, it's a slippery slope. I'd like to keep the deductible levels for the vast majority of your health plan as low as possible. So while option 3 is financially viable, it's my least favorite option on this sheet.
And you can see on the top, excuse me. You can see the impact on active employees, even with the original recommendation, the possible impact, in addition to the premium, is $24.50. For the other ones, and under option 3, it's $2,700. So, and they're only possibly getting maybe a 2% increase, depending upon things, and that would be towards the end of the 3rd or beginning of the 4th quarter.
So again, you're saying we would pick one of these forever. And so my question on what you called 1B, 1C, and then number 2 would be, are contracts at the time that they were signed, are any of those going to be impacted by this? So let's say we pick option 1 and we require retirees to roll with the actors. Is that going
So-
to affect any of the contracts?
I had a conversation with one of the city attorneys. There is nothing in the old collective bargaining agreements that defines their benefit levels. Now it becomes the city's decision on if you want to require it. There's been a past practice in the city, and what does that past practice trump what is in a written contract? I would want the opinion of the city attorney to be here before I would say recommending. What we're recommending in all of these options is a choice. So if they choose to take a different plan to reduce their premium burden, that's their right and their ability. We're not forcing anybody to take a new plan. Does that answer your question?
Sort of, because if we're saying everyone's gonna go with option one,
So if we go with option one, the actives and the post-2013 retirees don't get a choice. Their plan design is what it is, and their premium increase would be 7%.
It's the same as the original
Correct.
recommendation.
Other than that, the retirees could reduce their premium burden
Right.
from
and I'm not
11 to
reading
7.
option one, I'm just using
No,
it as an example. Okay,
Your pre-2013 retirees would have a choice. They can continue on the current plan they have today,
With
but
the
their rates go up
11%
11%. If they would like a 0%, they don't want to pay any more in premium, they can roll with the active plan.
which means they'll take on a higher deductible, co-pays. None of these have co-insurance, if I remember.
They do,
correctly.
they all
do
have 10%.
they all do.
They have a 10% co, okay, there it is.
It would be the same as the active plan that we're recommending.
But we should make clear, though, we're taking a bit of a risk with those plans, right? Because we don't know how many, we could get all of the post-2013 retirees to take it and take 7%, and no changes for the post-65, the pre-2013, and it would make the plan less viable. So there is some.
We'd be
risk
back
in
here in a
those,
year,
Perhaps.
looking at more changes.
It seemed that-
It's the, I'm sorry.
No, you go, you're the professional.
We're paying you.
It's the, this is the only way that we can reduce the retiree premium without completely gutting the active and the post-2013 retiree plan. To have 100 or so people with no out-of-pocket costs in their medical, I can't keep those premiums low enough to keep it viable for forever. So this is the only way I can give them a choice. If they like their plan, and to use the famous line now, if they like their plan, they can keep it, and that's not a lie. Or if they, want to reduce their premium burden, they just take a different plan. So
Or if all three stink, there's the private market as well, but
Yeah,
I feel these are
I don't
probably.
think there are better
Better.
plans and they're in the private market. Right. Yeah, it seems like option one is the best for everyone concerned, and it gives retirees that are affected a choice as to how to proceed. That seems pretty fair to me.
Sounds like HR is gonna be busy.
Yeah, that's right.
Answering questions.
And there are lots. Yeah, it's the management makes it more difficult. Different choices and different plans. Who's on what choice and what plan? And that's something that I think our staff can do.
We have 53 plans right now, so.
Yeah.
It's really for the actives, none of these affect. These are all pretty much the same for the actives.
correct.
Except the last one.
Except for the last one, then the deductible increases substantially.
Mm-hmm.
Even then, it's not a bad deductible.
When you go from 100
I
and
understand.
300.
Yes.
And you don't have the increases that other people are getting, that's a big challenge, especially, we tried to list, the median, salary is 56,000, so it's pretty impactful for employees at that level. Hopefully, a lot more people will use the flexible savings account so they can use tax money for that.
We still have an HSA plan available?
Correct. There's a little, right above the bottom, there's some changes to that would be part of
We haven't spent a lot of time on that just because there's, I think, 6 individuals on the plan.
6 or 9, yeah.
Although if these changes, it might make it more desirable for some people to go that route. And so if, let's say, we went with option one or option two, are we gonna allow people to switch back and forth every year, or are we gonna say you choose once and
Once.
this is the,
This is
Well,
choice.
I would
unless we
say
offer a choice again in the future?
if a pre-2013 retiree wants to come off the plan that they currently have, we would allow that choice to be made every year, but once they leave those older grandfathered plans, they can go back. They would then continue to roll with the active, so if the active plan again changes next year, their plan would be impacted as well.
Otherwise, they would leave right before they're gonna retire, so they could get the Medicare coverage.
there any other questions from the committee or the alderpersons present?
Mr. Chair,
Alderman Weigel.
back to the beginning. We were talking about the income side of the equation. How far below the levy limit are we right now?
Levy limit, we're really not restricted by at this point because we borrow each year, and so there's an adder in the levy limit calculation for that. What we're up against is our expenditure restraint limit,
Yeah, okay.
and we're $0 away from our top limit. We
And-
used it off.
And I've asked this question before, but I think other people might be interested, that expenditure restraint program is a state program that they offer to all municipalities?
Over $5 per thousand on a tax rate.
Okay, and and everybody that qualifies for it takes advantage of it? Would you say?
Communities have opted out at different times. You know, when your payment's 1.5 million, it's a lot harder to opt out than when your payment is 200,000 or something
200,000.
like that. If you had some kind of challenge or some kind of big project that you wanted to exceed the limits on, you would be more likely in that scenario. I've known over the last 15, 20 years, a handful of communities that have opted out of expenditure restraint, usually for 1 year because they want to reset it. Unfortunately for us, that would cost us $1.5 million and probably not very likely.
So a community could opt out and then come back into it the next year.
Right. South Milwaukee just did that.
Okay.
Mr. Chair.
Alderman May.
I think to your point, when you look at these, like you said, option 3 is a no-brainer, should be dropped. There's nothing to be gained by anyone, I don't feel, by doing that. So were you saying 1A, 1B, or 1C would really be the one that we'd want to go towards, right?
Mm-hmm.
And option 2
one
affects the.
1A though that's the original recommendation.
Yes.
I'm sorry, yeah,
1B
original,
being
One,
under the
1A,
title
1B.
option 1
That's right.
in
That's
this
right,
column here. Yep.
I call them 1A, 1B, and 1C because all three, I think, are similar and viable options. It's just what choice, if any, do we want to give to any portion of the retirees?
Option 2 would impact our employees more, or active employees, I should say, due to the deductible.
So under option 2, I want to clarify, the actives would have the same plan under the original recommendation, option 1, 250, 750.
Oh.
Option 2 is, you see at the top, it says retiree only plan.
Okay.
So if the retirees wanted to have a 0% and have their own plan, it would have a much higher in-network deductible than currently today.
So option 2 is retirement only, actives get the original
Yeah,
recommendation.
and some people might be wondering why there's such a difference in that deductible amount. Because there are fewer retirees, that we had to increase the dollar amount to make up the premium difference that we'd be losing. So they're basically subsidizing themselves in option 2, or 1C, as I've been calling it. Option 1, there's less, we need less room there, which is why we keep the deductible lower for everyone.
And really the difference between option 1 and option 2 is the pre and post retirees are both
Eligible to get to
0%.
0%. Under option 1, the post-2013 retirees would still be at 7%, which is down from 11, but still, I understand a financial burden to them, so.
And just from our past discussions regarding option 2, we've discussed setting retirees separately into their own plan, and we decided, no, we don't want to do that. That would be unfair to the retirees, that they're higher users of health insurance, and if you have higher users in a plan all along, all by themselves, well then they're going to have to pay higher premiums and higher deductibles and a higher co-insurance in order just to make that plan make it work. So yeah, I think that pushes us again to option 1 here. But I'm not prepared to vote on this tonight or act on this tonight necessarily. We've got lots of folks, of course, that are very interested, and I think we need some feedback. We do have another administration and finance meeting scheduled for Monday at 6 p.m. And that's Monday, January 6th. We could,
Do you need to?
please.
I was just wondering if there's a need for that. Are you going to hear feedback, or are you just getting feedback individually? Because I don't know that we have any more information to share. We can certainly share the same information again,
Sure.
but Or
Yeah.
people can watch the video. It should be available tomorrow.
Yeah, thanks, Ms. Grill. Where you're going, I think, is the right direction, right? I think I know where I stand and where I feel. Just want to take some time for other committee members to mull this over and hear from people. And then, right, we'd be looking at our next council meeting, which is the 7th.
Yeah.
Okay. Very good then, very good.
Mr. Chair,
Alderman Weigel.
are we gonna leave that sixth meeting on the schedule and potentially cancel it, or are
We
we?
would have to decide by tomorrow because we
Yes,
have to send an agenda out. So if you change your mind, you have to let me know before the end of the business day tomorrow so we could get the agenda
Well, Is
out.
there a consensus right here? I mean, I'm expecting to hear from some of our constituents. This is gonna be, this full document was a
It's
handout today.
posted already
It's
online.
posted online for everybody to read and mull over.
I'll be sharing it with the department
Does it have
heads
Alex's
after
phone
I
number?
unhighlight.
Alex's phone number?
Yeah, his cell
I'm at
phone,
home,
his
my
cell
cell
phone.
His cell phone number?
Yeah,
Mhm.
I'm
I
happy to give
put
it out.
mine in there.
Sorry, Alex.
Okay,
Thank you.
you're welcome.
So then, there's no meeting?
So no meeting is our consensus here for Monday. Yeah, I'll take it up at the council meeting next week. Okay.
And between now and then, if there's anything else you want us to look into or price out or questions, please let us know. We can certainly do that. We've been working on this every day since, literally every day, since the last meeting.
All right, is there anything else to properly come before the committee before we adjourn? Then can I have a motion to adjourn?
Move to adjourn.
Second. All in favor, say aye.
Aye.
Opposed? Ayes have it. All right, thanks, everybody.